Good afternoon, everybody. Assalamu alaikum. I'm going to talk about the newer technology. I'm actually a little bit more fascinated with the newer technology, although I don't have any shares on the company, but I'm going to just talk about it. I have 11 years of experience with renal denervation. I started the first case in Saudi Arabia and maybe the Middle East. I'm not sure. That was in 2013. And I've been doing renal denervation since then. I started with, let's see how this moves. Okay, I'm going to start with a summary because I know that people usually will catch the first two slides, and after that, the rest will be not very good kept. So, in my mind, the success of the procedure start with the pre-procedure preparation. So, proper patient selection, as my previous speaker talked about. I think we need to have a detailed interview with the patient. You need to understand your patient. It's not like the first visit or the second visit. You need really to follow them for a 2 to 3 months. Know exactly what's their factors, why they are not controlled. So you really can address these issues, because some of it is that they're non-compliant and you just need to do some lifestyle modifications. You cannot denervate everybody, all comers. You need really to filter them so you have your success on denervation. I've done maybe around 40 plus patients in the 11 years, but that's very low because it's very difficult to convince them to do the procedures, and I've been following them. So the proper workup is something that we need to do. And exactly, the proper workup has to be done with the teamwork, where you actually have your nephrologist, your endocrinologist, the cardiologist, and in part of it, because your family medicine is your gatekeeper, he has to be involved. So you have to convince the family medicine that there is something called renal denervation, and let's work together so we can do a success. You have to do a proper rule out of any secondary causes. So you have to do all the blood tests, all the ultrasounds, and then possible CTA or MRA. It depends on your center and the experience. And it depends on the renal function. If the renal function is in doubt that you're going to actually use more contrast, maybe then you bite the bullet and you take them to the table before you do, instead of knowing the anatomy, depending on the ultrasound alone, considering that 25% of this patient going to have an accessory renal artery that you have to look for, and you have to denervate if it is in a reasonable size, as mentioned earlier. The proper counseling with a clear expectation from both sides. Because what really because what Professor Subhi asked, who's the responders from non-responders? How would you define responders from non-responders? Because majority will have 5 millimeter drop, but that's considered non-responders. But the real responders are the one who's going to have the 15 or the 18 millimeter reductions, but not the one who's going to have the 5 millimeter reduction. Considering that, a 2% reduction of millimeter of mercury translated into a significant reduction in mortality and morbidity for hypertensive patients in the long term. So in my opinion, even the non-responders are really responders in a way or another, but below expectation. You have to plan the anesthesia with the patient, plan what kind of, some people, they don't tolerate pain, and especially with the Medtronic system. I'm not against Medtronic system, but Medtronic system with the longer denervation, the patient become uncomfortable. With the 60 seconds of denervation, they become uncomfortable. So you need to have a remedy, you have to be aware of the anesthesia, proper counseling, and sitting with the patient. The procedure, you have to start the program not by yourself. You have really to get a proper training. One of the things that killed the HN3 trial was the people are the first cases to do and the trial. They actually were the first time to operate within the HN3. Need the proper pain management. That's very careful because patient stabilization on the table. Need very predictable denervation method. So either use the catheter or the balloon. I've been telling Medtronic for 11 years, you need to come up with the balloon. I am a basket person. I've done majority of my cases initially with St. Jude system, with the basket. It was a great system. I wish it comes back. But now we have the balloon system, and I'm very excited about it. Because the catheter, with all the limitation that comes with using the catheter, I think renal denervation will evolve into a more multiple options of denervation methods. that we're actually going to learn. I think HN3 stopped and delayed the development that we should be seeing today on renal denervation because of the effect of HN3. Need to secure the proper hydration of the patient. You need to do proper maximize the denervation. And for patient comfort, I usually use a closure device for the femoral side. The renal artery anatomy is very important. You have to understand it's very rich and it's spread all across the vessel wall. When you look at the ideal RDN system, it should provide a complete denervation, because just in one area, it may not give you what. So you need, with the single catheter, you need really to do multiple. You take a longer time. Each one is a 60-second. Patient take a longer procedure. While if you have, and you need to protect the endothelium, because one of the things you always worry about is renal artery stenosis, and people still talk about renal artery stenosis and what's going to happen. Minimize the ablation and procedure time for patient comfort and safety. Provide consistent depth regardless of the vessel wall. This is how recall always talk about these things, because this is important. So if you really want to provide multiple, what is in the Paradise program, multiple denervation at all areas and a circumferential way with the depth and protection of the endothelium, I think that's where the other competition comes between the two systems available in the market right now. And I think the others are going to come more, and we're going to see more competition with more devices, and that's in favor of the patients, and it's more fun for us to actually try to serve the patient in a much better way. The 300 stenocation has been proved by the animal models, and it has been proven clinically, and this is the concept of the recall, where you have two areas with a 1 to 6 millimeter target depth and a 5 millimeter target width, and it's designed to deliver a 360 ultrasound energy. The target majority of the nerves around the main renal arteries, although the argument there is that you need to go to the smaller and more distal. I think the argument here is that if both are effective, then the argument is not very valid. If both showed the same result and the same reduction after 36 months, then the argument is actually both are effective. And that's what the FDA has voted for. So minimize procedure time by requiring 2 to 3 short 7-second ablation. The target majority of the nerve around the main arteries, avoiding the need to go more distal. That's the advantage of the ReCore. Automatically customize ultrasound energy delivery based on the patient-specific size vessel. So it's very predictable. It has 2 sizes, the 3 and the 8, and you can, after your imaging and knowing the size, you can target your vessel, and you know exactly what you're using. The catheter has the balloon and has the 360 transducer and sheath balloon catheter. The non-compliant balloon, which is the one that we have, a traumatic tip, and now started in the first cases in the Middle East has been done in United Arab Emirates by Dr. Arif Nourani, and we're starting the program in Saudi by the end of this month. The video here is very small. It's just showing with the thermosensitive gel how the denervation is happening, and it's a short video showing the ultrasound sonication completed, and the second ultrasound sonication with the 5 millimeter difference, and the cooling system, which is the balloon cooling system in the middle, try to cool the endothelium to avoid endothelial injuries and heating the endothelium, which is something carries an advantage. This is why it was 6 out of 6 in the voting of safety, comparing with the other system. This is the simple procedures. Whatever guide you are comfortable with, you can use. JR and multi-purpose, whatever, your or a Lima. I usually use the Lima catheter, but it's easier for me. And you could use it, and you can sonicate with the balloon. You can do 2 sets. Each one is 2 to 3 seconds. The program is there. There is multiple studies. This is against the sham procedure, and all has been shown an effective reduction. and it has been voted and approved by the FDA in the United States, of course, as well as the European. European really never really stopped, but the American stopped doing the cases only for clinical research, but the European continued to do their work, and we followed the European at that time. I was able to get it approved by the insurance companies in Saudi Arabia, and I was able to continue. Although it's expensive, and that's one of the limiting thing, and I hope that with the newer competition, that our distributor and the major companies that will actually lower their prices, so we can do it more for patients and convince the insurance to include even what we're trying to do with less resistance, or maybe as a solo program, as the record trying to do. So this is the reduction in the daytime ambulatory systolic pressure. It's been well shown that you have at least a 5 millimeter. These are the non-responders, if you want to call them. Multiple ambulatory pressure monitoring, and I do home monitoring. I don't do 24 hours blood pressure monitoring. I get them a device and I instruct them how to do it, and I gave them a table. I have a table, and they just rest for 10 minutes, avoid the meal for 2 hours, and they use the same hand. They do it from the upper arm, and I teach them in the clinic. I take my time with them, and they come to me after a week, and I monitor them. I titrate their medications, and I follow them closely with the endocrinologist and the nephrologist. So we are really work as a team. This is important because this is the way to success, and this is the way you can actually minimize that you are missing anything, because the nephrologist will look at it as a different way, and the endocrinologist look at a different way, and you are a cardiologist, your focus is you want to do the procedure. So you want to really to tailor it well. The ambulatory blood pressure study versus the sham procedures has been also confirmed the success of the Radiance program. There is bold analysis, which is showing that there is more than 10 millimeter reduction. This is the complications, which is really does not count. A lot of people will come talk about renal artery stenosis, about the damage to the renal artery, about the femoral complications. All has been really very low and is not of a concern at all. There is the long-term results with the 36-month and up to 8 years with the ACHIEVE study from the Radiance. There is the solo, which is this is something we really are interested of, which is seeing the reduction and the lower people with less medications, and that's really what we are aiming for. The ACHIEVE study is a multi-center single-arm study in patients with uncontrolled hypertension on 3 or more medications. This is the standard for the others resistant cases, and it has up to 8 years follow-up now and showing a positive response. What the number that I keep remembering and telling my patient, if you're going to be a responder, we're expecting that you're going to have about 15 to 18 millimeter reduction in your systolic blood pressure in 6 months' time. If you are not a responder, I'm expecting a 5 millimeter reduction. But majority of our patients are responders. I've been following these patients for 11 years. I'm very happy with the follow-up. I wish the basket will come back, because I loved the basket at that time of St. Jude. St. Jude does not exist, so I can't talk about them. But really, I had a great result with a very predictable denervation than moving a catheter right, left, and center and trying to denervate and look at the impedance and look at the heat and look at the other factors. That was very consistent. You twist it 90 degrees, 180 degrees, and you know exactly where your catheter is denervating. I think I'm done. They stopped me anyhow. But in general, I think we are now reviving renal denervation, and we're going to learn more. In my opinion, and I've been doing this for 11 years. If we lived in another 10 years, we're going to be sitting at a different level of renal denervation, because what HN3 did to renal denervation was a major harm of stopping a technology that could have helped millions of people. And I still think I've seen it at my own practice. I'm a strong believer of the therapy because I've seen it every day. I follow patients every day. And they come and I tell them, if I need to do it for you, they'll say, I will do it again. So they are willing to go for a second procedure because they really believe that they had a major benefit. Thank you very much.
شكرا.